You can use two sorts of dilatator for one-step dilatation or for stepwise dilatation with four small dilator. Personally, I use the one-step dilation. After you have instrument for manual bone rejection, you have a big recent punch with different degrees. I use it for remove the flavum because it's bigger and it's quickly. But when I approach the nerve roots, I use the smallest for more precision. You need two instruments for motor X bone resection. You have 4 different drill. The first one is a big one. I use it for bit quickly, and you can remove quickly the arthrosis of the facet joint, or you can open the lamina too. It's very, very aggressive, but you can see it's you don't have side guards on the extremity of this drill. The second one, it's a drill with a broad diamond. I use it for the hemostasis only. Sometimes for precision near to the nerve roots, but normally I use it only for the hemostasis. The third is an eccentric drill, like the first one, but smallest, and I use it when I just near the nerve roots, okay, for more precision. And you can see at the extremity, you have a side guard. And the last one is it's round, but it's very, very aggressive, and you have no side guard on this. You have like for the disclination, you have the instrument for coagulation and ablation. You have a bipolar hollow-thread electrode. It's between the electrode and between the plasma electrode. It's important. It's interesting to remove the soft tissue and to remove the articular caps of the facet joints to see the bone. Okay, but you can open this with a scissor or a small electrode, but with a bipolar electrode, it's faster. Okay, donc the techniques, you have a compression, you have a lumbar stenosis. The first step is the bone rejection of descending facets. You start at the extremity of your facet joints of the descending facet, and you drill the medial part of this facet just to the upper lamina. It's important to do this. You need to take your time for a good vision, and it's very important for the process. After this, you open a little bit of the lamina, upper lamina. After this, you can remove with a Carrison punch the flavum and the ascending facets. Okay, and in this step, you open the recess, and you liberate the passing nerve roots. Okay. After you resect the lower lamina, with a drill, and you remove the totality of the flavum ligament to the opposite side. And after, you resect with a drill or a Carrison punch the medial part of the facet on opposite side. Okay, and after it's finished, you have decompressed the both sides with one incision. Just a little movie. I drill the facet joints of ipsilateral side. You can see the flavum. I open the flavum on the ipsilateral side. I cut the bone, and you can see the passing nerve roots on the recess is totally freedom. Okay, you can see the nerve roots. After you remove the totality of the ligament fibulum just to the contralateral part side, and you drill the bone to the opposite side, and you can see your canal totally free on the both side. You can see here the contralaterally passing nerve roots. I'm sorry. Sorry. You can see one element with before the surgery and after the surgery. You can see you have not a lot of muscle damage. Sorry. You can see the sagittal view of the same patient. It was on small spondylolisthesis, and the canal is actually free. Sorry, and you can see the scar after 6 weeks. It's really really fine, really small. Okay. Thus, for the decompression, I don't speak for foraminal decompression, but for the recess decompression, you can use only and just the same material like disc herniation. It's a vertebrae standard. And for the over the top techniques, you need to use the stenosis from vertebrae because it's bigger and it's faster. What is the advantage of the disadvantage of these techniques? The advantage it's you reduce the traumatization. You have selective. You know destabilize your spine. It's more easy if you want to do a revision. In my small experience, I no have complications with this process. No infection, no hematoma. You have a very good vision with 25 degrees. The operating time at the beginning is long, but after it's the same time like traditional process, but you have no opening and no closing the patient. It's just the skin. The patient accepts this surgery because it's quickly for here. It's no hospitalization, and your assistant can see what you do, and it's for the training. It's important too. The disadvantage when you are a problem, you can do an extension. You must open. The other one disadvantage is the radiation. You use X-ray for the surgery, and you are just just on the X-ray, and like all the new surgery is a learning curve. It's you are big surgical times for the first surgery, but quickly it's the same time like traditional process. All the advantage and disadvantage is described in this paper, in this publication from Martin Komp and Sebastian Rutten, and it's very interesting paper. Yes.
So thank you, Dr. Schuller, for this presentation with all the details. Again, it's very important to see the learning curve and to see all the details that you showed. So again, I repeat that if you have questions to all the speakers, you can put your questions on the Zoom platform and leave your email, and all the questions will be sent to the presenter. So thank you for the 4 speakers of this session, and the next session will be driven by Maxime Chalali. So again, Maxime, I would like again to say that the speaker who had to cancel his presentation before, who was the Dr. Sasaki, I think, his presentation will be recorded and will be online anyway.
Dr. Zhang Wei, the presentation is recorded, and then we can play it after all the speakers finish their topic. Thanks.
Okay. So now is the turn of Dr. Marc Sadowski from Centre Santi in Lyon, France. The topic of presentation will be the learning curve uni on Biportal, transforaminal, and interluminal endoscopy, a fresh experience. So it's your turn, Dr. Sadowski.
So, can you hear me? That's okay? That's fine? Yeah? Okay. First of all, I really wanted to thank you for the invitation, Dr. Chalali and Professor Lerec. And all I have seen this morning, I have really been impressed by the knowledge and experience you all showed us today. So thank you very much for all the knowledge you gave us this day. So the aim of this topic is to share with you our learning curve of the Uniportal endoscopy. I call it a French experience, but it's a Lyon experience. So the story is the following. We are in a private practice in Lyon in France, and we are 3 surgeons. You see that we are from different ages. And for long ago we have been curious about these techniques, and we only could manage to see that on the YouTube and on videos, especially from Asia and from Germany. So we decided to go through the next step in December 2017. So the main problem we had is that there is no institutional or academic training. So that's why we had to move a bit and to go abroad. So we went in March 2018 in Germany and also in Austria, and then go back to Germany, Austria, and to Dr. Schuller that you saw just before. And we also went to Zagreb in Croatia. So after all these trainings, and I really thank the experts I met there, and we met there, there was the question of the learning curve, because we have been taught by the expert that they said start with approximately 100 cases and then go in more difficult cases. So we started with the 2 techniques, which is the thesis technique, which is a transforaminal, and the ilesis, which is a interlaminar. So for the transforaminal, we have been advised to start with disc herniation early and to avoid L5S1 at the beginning because of the iliac crest. And for the interlaminar technique, we have been taught to start with disc herniation and to avoid highly migrated, especially cranially migrated disc herniation or small windows. So the kickstart was really in February 2021. So until now, we have done 160 patients with 2 surgeons, Dr. Daster and me. All the patients were operated under general anesthesia and proud position. The levels, as you see, this is L5S1 for 64 patients and L4, L5 for 61 patients, but we have also 27 patients with L3, L4. And as we have been told that the more you go cranially, the bigger the foramen is, and it's the inverse size for the interlaminar window. You can see that we followed what we have been taught. I mean that with the transforaminal for 40% sorry, of our patients, which was pure L5S1 disc herniation, and for the other ones, it was pure transforaminal technique on the levels above. For the herniation types, you see that 73% were posterolateral, and that 11 plus 9, it's foraminal and extraforaminal herniation types, and a little bit of recurrent and central disc herniation. I wanted to share with you the operating time. You see, this is the operating time for the interlaminar technique, and all the interlaminar, you see that they're only pure posterolateral L5S1 disc herniation without stenosis, and you see that, well, I would say that the learning curve for interlaminar endoscopy is quite fast, with no real problem. For the transforaminal technique, the learning curve is a bit slower. And I wanted to analyze with you this operating time. You see a line of 90 minutes. And because at the beginning, when you switch to a transforaminal view, it's always a bit tricky to know if you have decompressed enough of the root. And that's why sometimes we were removing a little bit more of disc, and we didn't want to go through to reach 90 minutes because we wanted to preserve the exiting nerve root. And what is funny is that we have found that the fastest operating time was for extraforaminal disc herniation. So I would say that for us as beginners, we would recommend extraforaminal disc herniation, because I would say that it's much easier with the transforaminal technique than the classical open manner with a tube or a Wiltse approach. So on the opposite, you have the longest operating time that were down migrated disc herniation, that when you have to from a transforaminal technique to see down the pedicle, it's a bit more a bit trickier. We also wanted to show you at our complications for this year, and you see that we had 4 recurrent disc herniations, and 2 with the interlaminar and 2 with the transforaminal. I had a transient palsy for 1 patient that was caudally migrated disc herniation with a Tessis technique on L3, L4, just above a fusion. And we had no infection. The 5th case, we started with a dual leak. but this was the only one we had. And one interesting case was the discal pseudocyst. So this is an interesting case I wanted to show you. This is a biathlete that was training for the World Championships, and he was training very hard, and he had a L5S1 disc herniation, and he had been operated with this. I have the video here of the patient. And you see, this is a classical insolaminar L5S1, and with the classical disc herniation that we removed. But he came back when he was starting his training again, approximately 3 months after the surgery, with a recurrent S1 pain, right pain. And on the MRI, we saw this image, which is a pseudocyst. So the patient wanted to train, he didn't want to wait, so because he's an athlete, so we decided to operate him with the interlaminar technique. And so I wanted to share with you the video of this pseudocyst. So you see here the same, so the same technique, and you see here, this is the cyst, and you see here the serohematic fluid that runs out of the pseudocyst. And so we did an MRI on the day +1 after the surgery, and you see the shrinking of the pseudocyst. So as we didn't really know this complication, we were looking for it on PubMed, and we saw very nice publications on case reports, and I recommend this case report and literature review. And what is written here is that this is usually young patients with mild disc degeneration and usually hydrated disc. And the conclusion is that these pseudocysts are more likely to form using the interlaminar approach than the transforaminal approach. That was interesting. And you see these 5 radiographs of for these 5 patients. We had either foraminal, extraforaminal, or posterolateral disc herniation just on the disc above the fusion. And I'm sure that in 2020, before endoscopy, we would have recommended a fusion on the level above. And we did for all these patients a TESIS technique until now. I hope it will be good in the future. The patients are doing fine. So I think we avoided for the moment the fusion. And it's also the case for this female with the scoliosis, degenerative scoliosis, and you can see that she has disc herniation on 3-4, migrated and foraminal. And 1 year before, I'm sure we recommended a fusion on L3, L4, and we have made a transforaminal discectomy, and she's doing really fine. This was just in March last year, so I hope it will go well for the future. So our schedule was the following. You see here the years in the different colors and the complexity of the cases. So we decided that in 2021 we would do just only disc herniations for the learning curve, and then increase, and to do lumbar foraminotomy, over-the-top techniques, as you all have shown us. That is very nice technique. And after that, cervical and endoscopic fusion. So here, just in January, we have started decompressions. We have done a foraminal, unilateral. We have done an over-the-top technique, and even a synovial cyst that you can see here. So to conclude, I would say that it's for us, it's faster every day. We are very happy that our experts told us to be cautious. And I think thanks to that, we have quite a low rate of complications. And we can see that our indications increase as we do more and more complicated cases. I hope that in the future we will be able to avoid some fusions, for instance, for foraminal stenosis, adjacent level mild scoliosis. And I'm really happy to live in this recent years, because I think we live a real spine surgery revolution. And I really say that our energy, our fuel is enthusiasm. So thank you very much.
Thanks for this very nice presentation. Now it's the turn of Ralph Wagner, European leader in endoscopic spine surgery. The topic of presentation will be the transforaminal decompression of lumbar spine. He works in a ligamental spine center in Frankfurt. So it's your turn, Ralph.
Hello?
Hello.
Maxime, did you talk?
Now it's working. You need only to.
Okay, so it's working. I didn't get the last one. Did you make a question, or is it my turn now?
It's your turn. It's your turn.
Okay. Sorry. I thought it was. I didn't know we were ahead from the time schedule. All right, perfect. Sorry about that. I will just open up my lecture and share the screen. Let me see. Now I should be able to see it, no?
It's working. No problem.
It's working. Do you see the presentation mode, or you see the slides in the slides? I think you see the slides. Perhaps.
We see the slides. We see the slides.
Perhaps I can put it differently. It's on here. Okay. Now it's better?
It's better. It's working.
Okay. Well, thanks a lot, my dear friend, for the invitation. I think it's a great honor, and so far what I've listened, there were great presentations. The topic I'm covering is the Uniportal Transforaminal Approach, and I've been doing that for more than 14 years. Probably about 80% of my cases are endoscopic now in my practice, so I have lots of different indications and topics to cover. Well, my conflict of interest is that I'm actually working as a faculty for the Trimax company. Maxime, you know that, and but I don't think I will make any advertisement. It's just the technical stuff I will present. Now, when we talk about the intervertebral foramen, we have in the normal anatomy, we have the intervertebral foramen is limited by the disc. by the yellow ligament and also changes of the facet joint. And normally the nerve root, the exiting nerve root, is covered by fat tissue. So when we come to degenerative diseases, this might change. You see when the disc space collapses or we have telescope phenomena in the foramen, we might have to deal with a changed and alternated anatomy, either due to herniated disc or due to bone structures. Interesting wise,
there is a problem. Slides are not moving.
Ah, they're not moving. I don't know why that happens. Let me see. I should have. I try. I will try to restart and share it again.
Hello, Professor Weger. We should share your screen. The first, yeah.
Now, do the slides move now?
Yes.
Are they move? Yes. Okay. So you see the when we have this telescope phenomena, we have also folding of the yellow ligament, that this might compress the exiting nerve root. We have the goal of the surgery should be to have a fast and safe access, to be pathology oriented. This is important, especially if you have several degenerative problems. And of course, especially when you work in the neuroforamen, it's also the surgical time which decides over complications like hypalgesia or dorsal root ganglion problems. The indications for transforaminal is the intra-extraforaminal disc herniation. It's a very useful technique for recurrent disc. L5S1 and higher, whereas L5S1 might be difficult in some of the cases, especially in male patients with a high iliac crest. And don't forget, we can use it if we have a same-sided pathology on different levels. The complexity of the transforaminal endoscopy actually augments from the normal disc herniation in the young patient up to stenosis surgery. In the beginning, I would avoid L5S1 pathology, and I would also avoid problems of primary or secondary stenosis. By the time, I think you will get the experience to do that also in advanced cases. What is the advantage of a microdiscectomy? Actually, we do very little bone work and cause less instability. There's studies which show that after 2 years, the failed back syndromes in endoscopy, especially in transforaminal endoscopy, are less than in microsurgery. It spares the muscles. We do not open the spinal canal. We use an anatomical margin, which is already preset. And you can do, don't forget, you can do operation on recurrent disc herniations with almost very little or less or not at all scar tissue. The disadvantage of the technique is that we have a two-dimensional technique compared to the microsurgery. We have 3 dimensions. So the third dimension is the feeling you have with your instruments. L5S1 might be sometimes difficult due to that small neuroforamen and the fact that we have the biggest dorsal root ganglions. And the approach determines your possibilities. If you're off with the first approach, you will have problems. You will have problems further on. Now, this, for example, is a 28-year-old female patient who has a 2-level pathology, and you're able to do this, the treatment of this patient with a single incision only. The anesthesia, it's always a question, do we do it in general local anesthesia? There's advantages in both. I personally prefer the general anesthesia, but with a normal setup, you can do it in local anesthesia. You can do it with spinal anesthesia, even so that's not the problem. I prefer the general anesthesia without muscle relaxants because the patient, once he's positioned, there's no more movement normally. The disadvantage of the local anesthesia might be if the anesthesia doesn't stay. The anesthetist doesn't stay in the surgery room and is not motivated. Sometimes the patient sleeps and doesn't react at all. So it might be better to do it depending on your setup. Now, when we take a look on the anatomical borders, we see that the literature Cambion triangle actually has a dimension of 2 × 2 centimeters. But the real, I call it the bony Cambion triangle, depends largely on the width of the facet joint and also the height of your disc. If you have a reduced disc height and if you have a large facet joint, you have a very small corridor. Don't forget that, because that's important to avoid complications. This, for example, is a wide facet joint. If you want to approach it in a transforaminal technique, you need to take down a lot of bone, and I compare that to a tunnel. The shorter the tunnel is, the better you see through. If you don't have, let's say, if you don't have a large enough tunnel, you have to perform a foraminotomy. Now, the position of the patient, there's 2 options. I think for beginners, it might be easier to position the patient in prone. I personally do the positioning in a lateral position. The reason why is very simple. First of all, in obese patients, you don't have pressure on the abdominal structures and therefore less bleeding. Second of all, the dura falls down with the gravity, so it kind of gets out of your way. And the third thing is that I think the working position is nicer for the surgeon, because you don't have to fight against the gravity of the endoscope. The only difference when you work in a lateral position is that you actually turn the endoscope towards you. So right and left and right is changed. This is causing sometimes problems in orientation. When we take a look on the transforaminal techniques in the literature, we see all kinds of different techniques. Basically, I would say the main techniques are the far lateral approach, which is supported by the Sebastian Ritten group. So you see the distance of incision is far lateral. We see the intradisciple technique. It's a technique always supported by Tony Young, and we see the let's say craniocaudal technique with the foraminotomy before the surgery to allow to take down pathologies. Now, let's say far lateral technique. The far lateral technique is very useful if you have medial problems in the spinal canal, contain disc herniation, and the advantage is that we have a good overview on neural structures. But we have a big disadvantage in that there's a high risk of exiting nerve root injury or a hypalgesia. The reason why, let me see, the reason why is actually we come from a very far lateral entry point, and this leads to a good view and a good movement inside the spinal canal, but has the risk of compromising the exiting nerve root. The reason why is that the Cambion triangle is a 3-dimensional structure, and with that technique we reduce it to a 2-dimensional structure. So to avoid that, we have to start on the SAP in a so-called trans-SAP approach. If not, you have a high possibility to actually have problems with the exiting nerve root. And you see it in this picture, this is the problem. So be sure when you choose this technique, which is in my opinion useful, to stay posterior and to avoid the pressure on the exiting nerve root. There's one publication which actually shows the problematic cases have a very small distance from that facet joint to the nerve root. The bigger this distance is, the less we have this risk of exiting nerve root injury. This is a case, so you see this medial disc herniation, left-sided leg pain. Good case. The pathology is actually in the midline of the spinal canal. You see the positioning of the working tube and the instruments and the intraoperative. Can you see the video? Does it work? And you see the intraoperative picture. So you can actually, with this technique, look underneath the dura, and you see here the contralateral nerve root. So this is a very useful technique if you're dealing with midline pathologies. The next thing is the so-called Torsolateral Approach. So it's the approach for intra-extraforaminal pathologies. The approach is similar to a discogram. So we actually enter the disc about 8 centimeters from the midline. And the goal is not to decompress the paramedian area, but to work in the intra-extraforaminal position. Therefore, a more parallel position to the disc and extraforaminal area is helpful. And again, same issue as with the far lateral approach. We have a high risk of ganglion irritation. That's due to the fact that we actually spend a lot of time working in that area from the dorsal nerve root ganglion. Let me see. So the approach is a little bit more medial. Here you see the 8 centimeters, and you see that the limitation of our instruments is actually the medial pedicle at the midline in the pedicle. We don't have to actually come from cranial to caudal to work in the lateral recess. It's helpful if you're more parallel. Why? Because with the turning maneuver, we can actually rotate the endoscope by 180 degrees, and this allows us to work in the intra and extraforaminal area as well. But you see that in that slide that actually by turning the endoscope towards cranial, we look for the axilla of the exiting nerve root, and then we follow the exiting nerve root to the extraforaminal area. And when we do that, the endoscope position is changed by 180 degrees. The only thing you have to take into account is that you need to be orientated. So what I always do, even in cases with an intra-extraforaminal pathology, I prepare the traversing nerve root, because this is my key structure when I change the endoscope. Because when you rotate the endoscope, the position of your nerve root is changed, and you have to be orientated. For example, here I'm looking in the lateral recess. So you see the nerve root is not horizontal anymore, but it's now coming from 1 to 7 o'clock or 8 o'clock. Here, parallel, the starting point with the SAP, the lateral recess, and intraforaminal view and the intraforaminal view, you see the exiting nerve root. Again, the nerve root changes, and extraforaminal view is completely different. So you have to be orientated. This allows you to work faster and to avoid complications. This is one case example for an intra-extraforaminal pathology here. On the right side, perfect indication. You see the paramedian area is clear, extraforaminal pathology. So the placement of the scope, and then here the intraoperative video after decompression, turning the endoscope. You see here the exiting nerve root comes out, and I follow it to the extraforaminal area. So this is the extraforaminal disc space. So this maneuver is, in my opinion, a very simple maneuver for those extraforaminal pathologies. Now, problematic might be the hidden zone pathology. You see it here. There's different options. You either open up the foramen and take down the cranial part of the pedicle, but you can also approach it through the pedicle or from the contralateral side. Now, the contralateral approach, I don't use it regularly. In some cases, it's helpful, especially if you have a soft disc herniation on the opposite side. The disadvantage of this approach is might be more bleeding of the epidural veins, because you're actually working the whole way underneath the dura. Let me see. You see here the intraoperative picture of a case, but it allows you to work in the hidden zone pathology of the opposite side. It's important to have a large enough neuroforamen. So in the upper levels of the spine, this approach might be helpful. In the lower levels, since the foramen is in most cases smaller, you have to do a lot of bone work to reach it from the opposite side. And the next thing is the transparticular approach. So this approach is probably about 5-6 years old, and it was actually helpful when we have hidden zone pathology close to the pedicle, so far caudal sequestrated disc herniations, and you see the approach is through the pedicle. I normally use a Yamshidi needle to perforate it, and then open it up after the Yamshidi with the reamer. Bring in the working tube and do the resection and the opening of the medial pedicle with the diamond burr. And what we do is actually we drill a hole through that pedicle in order to reach pathologies which are in that hidden zone. This is an example. So you see this far sequestrated disc close to the pedicle on this picture. And let me see if it starts the video. And you see that's after opening the pedicle. So we see the traversing nerve root. You see that it's a hole in the pedicle. Actually, the normal lateral recess would be here. So it allows us to treat those far caudal. This is the upper border of the pedicle. So to get hidden zone disc herniations. Here, the intraoperative picture and the postoperative CT scan shows you that the nerve root is after that drilling of the pedicle. You see the nerve root completely free. There's some postoperative CT scans which actually show that after 1 year, this opening of the pedicle is closing down by itself. Then this is another case, 81-year-old male patient, L5 radiculopathy on the left side, and you see this patient has this vacuum phenomena due to an old disc herniation. Again, the transparticular approach, opening of the pedicle, entry of the working tube, and then this is a postoperative CT scan with a subtotal resection of that particular area. But again, this is a patient, 81 years old. He recovered very well, and it was a very small and minimal invasive surgery. I've actually done that in local anesthesia. And again, end of the surgery, you will see that the nerve root is completely liberated from caudal to cranial. So a complete decompression of the L5 nerve root. The disc space is somewhere up here, and no more compression. Now, the standard craniocaudal athesis approach goes with the foraminoplasty. The approach is a little bit different. Side position, as you see it here, with that changing of the sides. Access planning, actually, you have to know where your pathology lies. Most of the time we have the problem in the lateral recess, so you have to plan that before the surgery. Then be sure to avoid rotation in your X-ray. Make a thorough planning. So this is the facet joint line, mostly in L4-5 and L5-S1. We go in close to the iliac crest in this triangle. Depending a little bit, if we want to go more caudal, we have to come a little bit for more cranial. If we have to go more cranial, we go further lateral and further horizontal. Then you plan the trajectory. Normally it goes over that interarticular portion, aiming at the lateral recess, either starting with the needle or Yamashita needle. You see the first positioning of the needle, and then the model of it. So we're coming directly underneath the shoulder and into the lateral recess with the without entering the disc. So it's a intracanal technique. Then a dilation of the soft tissue. After the dilation, there is several instruments. This is a coronary reamer, which is used to perform a foraminoplasty. And this foraminoplasty is actually it's actually guided with the C-arm, and you see the medial pedicular line is important to respect, because if you overcome, you have a higher risk of injuring the traversing nerve root. And then you see the reamers come in different sizes. The Trimax company has it in different colors. The placement of the tube. And this is great because without opening the yellow ligament, we are exactly at the site of most of the pathologies. So we are coming in that neuroforaminal area, and they are exactly on the right spot. And then you have bring in the working tube. You see it has a small bevel. The small bevel shows to the opening of the working tube. The endoscope is a 6.8 millimeter endoscope with the 30-degree optic angulation. You saw the picture of that traversing nerve root. So after the surgery, you see the ventral part of the SAP, you see the axilla, the exiting nerve root, and you can be sure that there's no more compression of that nerve root. Here you see the technique again in the X-ray, reaming with the reamers. There's also bone drills to do that. I use them especially in transforaminal fusion cases. then positioning of the final instrument intracanal, and you can reach also caudal sequestrated problems. Now this is a case. So this is a 58-year-old female patient with L4-5 on the left side. You see this paramedian medial disc herniation. First position. My working tube was a little bit inside the disc, and then you see that you can also perform the foraminoplasty once you're in with the scope under direct optical control. It takes a little bit more time, but it's completely controllable. After that, you identify the traversing nerve root, take out the compromising structures, and have a good result. Last but not least is the intradiscal technique. This is the technique which is used from Tony Young. So the idea behind that technique is to go into the disc and then take out the disc material, which actually compromises the nerve root. I use that for contained disc problems, as you see it, for example, here. So you enter the disc and you first of all take out some of the volume of the disc, and then you take a look on your nerves. So you see it's about 10 centimeters from the midline. This is a case with a contained disc herniation and intradiscal approach. You see it on this video that after the surgery there's a good decompression, but also there's a defect in the posterior ligament. And this is probably the reason why some people have the opinion that the transforaminal technique causes more recurrent disc herniations. If you work too much in the disc, you have a predetermined opening of the disc space, and this can actually lead to a higher incidence of recurrent disc herniations. So L5S1 is something different. Here you have to take into account that we have the biggest exiting nerve root, dorsal root ganglion, and therefore it's advised to enlarge the neuroforamen. In those cases, I start with the Yamshidi nail dock on the SAP in the so-called trans-SAP fashion, opening and then placement of the working tube. You see here the different techniques of decompression. Starting with actually the decompression of the SAP, as you see it here. So this is a posterior decompression, opening up of that foraminal area. Here you see you can do actually the same on the ventral part of on the posterior part of the vertebral body. So you see here an anterior decompression. You can do that more to the midline and open up the complete area underneath the nerve root. So decompress the central spinal canal. You can work in the intra-extraforaminal area and take down intra-extraforaminal osteophytes, and you can also work through the pedicle as we saw it before. Now this is a MRI after lateral resist decompression on the right side, and you will see in the following picture the CT scan. The CT scan after medial decompression, again with sparing of the yellow ligament, a good anterior decompression. Here, one case of neuroforaminal stenosis of L4-5, and you see the postoperative result and the amount of opening of that neuroforamen without resecting the facet joint. Now we are on pre-postoperative control pictures. Now to conclude it, the transforaminal endoscopy is one tool in the toolbox, and you saw in this great series of lectures that we now have interlaminar uniportal techniques. We have the possibility with the biportal technique to also cover more complex cases. I think the biportal technique will be a great technique because of several reasons. First of all, it might be very useful in the future when we have a treatment of a complication like dural tears. The second of all, I think it's very helpful and necessary if we do endoscopic assisted fusion. All of those techniques should be standard in spine surgery today. And when you treat degenerative disease with the transforaminal technique, be sure that you work on the bone and not in the disc, because this avoids complications. Thanks a lot. Always happy to receive some colleagues or surgeons. Right now we're doing about 12 to 15 endoscopic cases a week, so there's always a big variety of different indications. Thank you.
Thanks, Ralph Wagner, for your presentation. Very complete presentation. Now, the next speaker is Dr. Juan Carlos Ordonez from Trauma Medics, Ecuador. The topic of this speech will be orthopedic surgeon's challenge in the initiation of UBE. So it's your turn, Dr. Ordonez. Dr. Ordonez, yes. You must open your micro. You must open your speaker, please.
Can you hear me now?
Yes, very good now.
Okay, thank you very much. Let me please to share my presentation. Can you see the? Can you see my? Okay. Okay, my topic is the challenge that I confront in the initiation of the UBE.
Excuse me, can you put on all screen your presentation? Okay, thanks.
Thank you. The topic is the challenge that we confront in the initiation of the UBE technique. And this is first, I'm very grateful for the ISUBE for the invitation. It's an honor for me to be here, and with so many spine surgeons of great experience, and that we believe that we could be better and better solutions for the health of our patients. And well, basically, I have a lot of experience with arthroscopy, knee arthroscopy, and spine surgery. And when I was in class with Dr. Sangwei, he told me it will be easy for me to do this kind of surgery, but I think you have to need the expertise in the use of the camera, but it's not the same word, it's not the same thing than arthroscopy. You have to be careful. So for many details during this technique, the first challenge I have to be sure is that the water that get inside the spine get out the spine. So it's very important to have to make the not only the position of the portals. So it's very important that you have connection, a real space between the two portals, so that the inflow is very easy to get out the spine. The water to get in is very easy to get out without suction. In the first surgeries, I start without pump, but finally, I am right now. I am using the water pump and without complications. But this is fundamental. Make sure that the portal is good placed, and you have to make a good dissection of these two portals, but to get the water out the spine. Then you have to find out where you are inside the spine with the camera. You have to triangulate. Whereas knowing arthroscopy, you have to the first surgery we do. I use the 30 degrees camera, and this is a lens arthroscope that I am very familiar, but in the spine has limitations. It's